I'm going to start with a summary of this talk. First, you want to follow protocol when doing this examination and pay careful attention to technique. The second part is about interpretation, and I want to point out that the phrase chronic thrombus is something that we don't want to use. We might want to say chronic changes or sequelae of prior thrombosis. And the third, it is important to know certain pitfalls that you may face in order to avoid making a misdiagnosis. A little bit about deep venous thrombosis. It affects over 2 million individuals in the United States each year, and diagnosis is critical because acute pulmonary embolism occurs in up to 50% of cases of untreated DVT. It's also associated with a mortality rate of 30%. Deep venous thrombosis is the most common reason to order lower extremity duplex sonography. 80% of emboli to lungs arise from leg thrombus. And not only that, in those that may or may not have pulmonary embolism, it can lead to post-thrombotic syndrome and venous insufficiency. Now here's a list of the risk factors. The top three that I wanted to point to are trauma, surgery, and malignancy, because protocols or practices may vary in this population. Patients with deep venous thrombosis may present with pain and swelling in the calf. This pain may increase with ambulation and be relieved with rest. Patients also experience warmth, tenderness, and redness in the calf or in the area that is affected. With iliofemoral DVT, patients may experience buttock or groin pain, and this may extend to the medial thigh. They may also present with proximal leg swelling. Also important to note that in many cases, patients may be asymptomatic. What are the indications for lower extremity examination? Well, patients with suspected pulmonary embolism, those experiencing leg pain, swelling, or erythema, the presence of a palpable cord. Patients may have a lower extremity Doppler exam after treatment. Pre- and post-operative patients may also get the study, as well as high-risk patients with predisposing factors, as I indicated in the prior slide. Our protocol includes evaluation of the common femoral vein and popliteal vein, certain portions of the saphenofemoral junction, and central portions of the deep femoral vein. We also include the calf veins in our examination. Anything that is abnormal should be documented, as well as ancillary findings. And we do the examination in grayscale and with Doppler imaging. We don't normally image the anterior tibial veins unless the patient is symptomatic in this area. Augmentation is optional and can be used to answer questions or when the examination is unclear. And the gastrocnemius and soleal veins may also be evaluated if those areas are symptomatic. Now, it's important to position your patient properly, and there are several ways to do this. The way we prefer is to have the patient lying at an incline to allow pooling of blood to the legs, and have the leg in the frog leg position. This will allow you to do the femoral popliteal venous system and then do the calf scan at the same time. Now, when doing the calf scan, we like to start from the foot and progress centrally, and having your hand in this position will allow you to augment with your pinky while doing the examination, especially when you have trouble finding the veins. This also allows you to angle the probe in order to look at the posterior tibial and perineal veins without repositioning the patient. When that doesn't work, or when you cannot image deeper structures, you may try a lateral approach. And here you see the patient now lying on their side, and you can access the perineal veins and bring them closer to the transducer. Now, one other thing to point out is the femoral vein as it traverses the adductor canal. Here we have a diagram from the Atlas of Human Anatomy, and you can see that the femoral artery and vein dive down and go in the adductor canal and deep to muscle. And this may limit your ability to compress this vein during the examination. And one way to overcome that is to bring your hand underneath the thigh and compress from both sides. And as you can see on this ultrasound image of the femoral veins, The veins are deeper and beneath the muscle, making it difficult to compress from above. Now, compression is the most important part of the examination. We do the compression in the transverse plane in grayscale, and we compress the venous structures every 2 to 3 centimeters. We look at the common femoral, and popliteal veins. We designate the femoral vein as central, mid, and peripheral, with central being closest to the heart and peripheral being farthest away. We document areas that do not compress, and again, as mentioned earlier, it may be useful to use 2 hands when compressing the vein in the region of the adductor canal. Doppler can be used to confirm the presence or absence of flow. We can use both color and spectral Doppler, and we can also use it to document the most proximal extent of thrombus. And here we see a color Doppler image with color filling the vein and showing that there is nothing that's preventing the color flow or implying that there's thrombus. Spectral Doppler can also be used to confirm flow or confirm the absence of thrombus. It's important to note that there may be some respiratory and cardiac variation within the waveform that is obtained, and this can vary from patient to patient. We do not include augmentation as a standard part of our examination, but we can turn to it when we want to clarify a question. Augmentation can be performed by externally compressing or squeezing the calf, or we can have the patient dorsiflex or plantar flex their foot. When this is performed, we may see flow accentuation in the vessel, which indicates patent venous return and indicates that there's likely no significant obstruction to venous flow. Okay, moving on to interpretation. These are the criteria for a normal vein or normal study. The vein is normally larger than the adjacent artery and it has an ovoid shape. The size may vary with respiration. The vein lumen should be anechoic and the vein should have a thin wall. You may see slight dilatation where there are valves. And the most important part of the study, the vein should be easily compressed to exclude the presence of thrombus. Starting from the foot or from peripherally, here's an image of the posterior tibial veins. The veins are paired with the artery in between, and we take images in transverse with compression and in long axis with color. The perineal veins are also paired with a single artery. When imaging the femoral popliteal venous system, we see the common femoral vein side by side with the artery. Note that the vein is thin-walled and is larger than the artery with an ovoid shape. The femoral vein typically lies below the artery, and then the popliteal vein, depending on where you scan it, may look like it's above the artery or superficial to the artery. And here we see that the vein, again, is larger than the artery with a thin wall and anechoic lumen. You may sometimes see the valves as thin, mobile, linear structures that project from the venous walls, and you may watch the valves open and close. And sometimes you may see a focal dilatation in the vein where there are valves, and you may see increased echoes due to the slow flow of blood behind the valves. With spectral Doppler, you should see spontaneous or continuous flow at all times. You may see it go to baseline due to respiratory phasicity, with inspiration having decreased flow and expiration having increased flow. Valsalva and augmentation can be performed to see increased flow during these maneuvers and suggest the absence of thrombus. And again, flow should be unidirectional. As with bidirectional flow, that may suggest venous incompetence or insufficiency. Now, when interpreting abnormal studies, we see non-compressibility of the vein, implying that there is something within the lumen, in this case thrombus. The vein size may be increased and much larger than the artery than expected. And again, with thrombus, you may see intraluminal echoes or bright material or heterogeneous material within the vein. And acute thrombus may be deformable, or when you compress it, it can decrease in size. Now, sometimes the echoes are not easy to see, and this is why compressibility is the important part of the study. This is an image from the right common femoral vein. This was taken before compression. We see a little bit of echoes here, but nothing in here. But with compression, you see that we cannot completely coapt the vein walls because there is thrombus within its lumen. Here is a video of that same patient, and you can see that with compression, you can see the thrombus a little bit more easily. Thrombus can fill the vein and can expand the vein, and you can see here that this vein is filled with thrombus but is also much larger than the adjacent artery. You may see echoes within the lumen, and you've seen from the prior pictures that the echoes may vary. You may see more echogenic material or less echogenic material, and it sometimes may look anechoic depending on the settings in your machine. Acute thrombus tends to be deformable. So you can see in this picture, we have the pre-compression image and the post-compression image, and you can see that the thrombus within the lumen is deformable. And then we have this thing called free-floating thrombus, which isn't exactly completely free-floating, but very loosely attached to the vein walls. And you can see the thrombus projecting within the lumen. And you can see that it appears to be free-floating or moving within the vein lumen on this cine clip of the common femoral vein. With color Doppler, it seems again to be unattached because you see color projecting around the thrombus. But again, this thrombus is loosely attached to the vein wall. Now, with a Doppler examination, the presence of thrombus may present with either absent color or filling defects within the vessel lumen. On spectral Doppler, you may see loss of phasicity or absence of respiratory or cardiac pulsatility. Okay, now what does thrombus do over time? Well, it may completely resolve. It may retract or recanalize. It may appear more irregular over time. Over time, the vein may become scarred, and you may have remnants of the thrombus with synechia or scarring. There may be wall thickening, which may prevent compression and present as a pitfall to your evaluation of the vein. The thrombus may calcify and again cause wall thickening. Wall thickening may result in a narrowed vein. Thrombus in the region of valves can damage the valves and also present with synechia. Or the vein may become permanently occluded with collateral vessels in this area. I have some images to show this. Over time, thrombus can appear irregular. It can increase in echogenicity, may not. As the thrombus is resolving, it may leave behind a web or a synechia, and these may sometimes be attached to scarred valves and cause incompetence of the valves. Over time, the thrombus may calcify and not completely resolve. With recanalization, you can see that the lumen is established centrally with the thrombus adherent to or lining the walls of the veins. Here, over here, you see there's thrombus lining the venous wall with patency established centrally. And again, over time, the vein may become scarred and may have a thickened wall. Now, notice here the vein is no longer much bigger than the artery, but also the wall thickening is preventing compression or complete coaptation of the wall. The vein may become narrowed due to scarring over time. It may remain patent, but I want to point out again that it is smaller than the adjacent artery. it may become narrowed and chronically occluded, and at times you may not even see the vein. So the clue here is that we have the artery, but not the adjacent vein in this picture. Sometimes you can see the vein, but it is chronically occluded and with no flow within that vein. Sometimes the only clue to a prior thrombotic event is the presence of collateral vessels. These vessels do not have the same appearance as the native vein. They may be more tortuous. They may not sit adjacent to the artery where you expect the native vein. The native vein may not even be seen. Now, some pitfalls to face when you're evaluating a patient for DVT. You may have a patient that cannot be scanned optimally, either due to their body size or due to edema in their leg, or maybe the presence of bandages. These may limit your ability to compress the vein. Mistaken identity: if you're looking at the collateral vessel and not the native vein, you may mistake it for a patent native vein and miss the thrombus. Duplicated veins may also be confusing. Thrombus age cannot be assessed based on its echogenicity. Slow flow may not be detected on color Doppler, and compression may be your only clue to the absence of intraluminal thrombus. Recurrent DVT may be difficult to age and may be difficult for you to tell the difference between acute or chronic changes in the vessel. Improper use of color or settings in your machine may lead you to believe that there is no flow within the vessel, and reduced flow within the vessel may not be detected with color Doppler. Now, one misconception is that collateral vessels occur over time, and that if you have collaterals, this is a chronic situation. Collateral vessels may open up acutely in this patient. You see there is distension of the vein. We don't see the thrombus that well, but there are collateral vessels in this area, and this is a patient with acute thrombosis, not a chronic situation. Now, sometimes the presence of a duplicated vein may not clue you into the presence of a thrombus. So in this case, we have a patient with a duplicated vein, but in this study, because the vein compressed, it was read as a negative DVT, and the fact that the duplicated vein was thrombosed was missed. On the follow-up exam, you can see that there were 2 femoral veins, with both of them now being without thrombus. One clue, perhaps, to use is the vein here is smaller than the accompanying artery. And when you see this, you might want to look for a second vein in a duplicated system. The other possibility for the vein being smaller, as mentioned earlier, is a chronically scarred vein. But in any event, if you see that the vein is smaller than the adjacent artery, be careful to look for the duplicated vein and not miss that that vein is filled with thrombus. Now, as I mentioned earlier, chronic thrombus is not a phrase that we like to use because that implies the presence of a situation that is treatable. But in this case, this is a synechia or a scar or a web, and it is a chronic sequelae or a chronic change related to prior thrombosis. And therefore, the phrase chronic change or scarring may be more appropriate and not lead to overtreatment of the patient. Now, slow flow may present as a luminal filling defect or echogenic or echoes within the vein lumen and may be mistaken for a thrombus. But in this case, you can see that the vein easily compresses and the vein walls completely coapt, and that this echogenic material is slow-flowing blood. Now, patients may present with acute thrombus in the setting of chronic changes. In this case, the vein walls are thickened due to a prior thrombotic event, but it is much larger than the adjacent artery and is unable to be compressed due to the presence of acute thrombus. Lower in the leg again, you can see that this vein is not as large as you expect it to be because of chronic scarring, but there is acute thrombus within the lumen. Too little gain may imply the presence of mural or recanalizing thrombus, so it is important to optimize the gain and fill the vessel lumen. Now, in some patients, it may be difficult to adequately visualize compression of the vein. Sometimes you can use color to localize the vein or identify the vein, and then do compression in grayscale once you find the vein. Now, as mentioned earlier, echogenicity is not a reliable sign of thrombus age, and acute thrombus may also appear echogenic. You can see that this vein is filled with echogenic material. The vein is enlarged, much larger than the adjacent artery, and then you can see that we are unable to coapt the vein walls due to this thrombus, but also that the thrombus is deformable, which is a characteristic of acute thrombus. Some limitations you may face: patients with open wounds cannot be compressed in that area. Dressings may also limit your ability to compress, especially in patients who have had recent surgery. Patients who are large or who have enlarged legs due to severe edema may not be able to be compressed adequately. Calcification in the artery may limit your ability to compress, and patients who have recent surgery or in pain may not be positioned adequately for the examination. So in conclusion, when performing these examinations, it's important to follow protocols as to not miss important findings. It's important to pay attention to technique so as to not have false positive examinations or false negative examinations. Also, it's not desirable to use the phrase chronic thrombus and imply that you have a treatable situation. Perhaps use the phrase chronic changes or scarring or sequelae of prior thrombosis when reading these examinations or interpreting the examinations. And last, to beware of pitfalls so as not to make a false diagnosis. Thank you for your attention and for watching this video. I hope that you find it useful.